the real reason your hair is falling out, and what science says you can actually do about it. I am Dr. Daniel, and today I want to talk to you about something that affects hundreds of millions of people worldwide: hair loss. Not the superficial kind of conversation where we just say, use this shampoo, or try this oil. I want to go deep. I want to show you the biology, the mechanisms, the research, because once you understand what is truly happening inside your scalp, the solutions become far more obvious. Let's start with something that most people get completely wrong. The hair follicle is not dead. If you are losing your hair, or you have already lost a significant amount, the first thing I want you to understand is this: your hair follicles are, in the vast majority of cases, not dead. They are dormant. A landmark 2024 study from the University of Virginia confirmed that the stem cells responsible for initiating hair growth are still biologically intact and alive, even in people who have been completely bald for years. These are called hair follicle stem cells, or HFSCs, and they sit in a structure called the bulge region of the follicle. In active follicles, they receive signals that tell them to divide, differentiate, and push out new hair. In people with pattern hair loss, those signals are being blocked. Think of it like a seed that is sitting in frozen soil. The seed is alive. The problem is the environment around it. So the real question is not, why are my follicles dead? The real question is, why are my follicles not receiving the signals they need to activate? And the answer to that question leads us to the number one physical barrier in hair loss that almost nobody talks about. The physical barrier: fibrosis and scalp calcification. Multiple peer-reviewed studies, including a significant paper published in PLOS One in 2023, have shown that in people with androgenetic alopecia, the medical term for pattern hair loss, the tissue surrounding the hair follicle undergoes a process of fibrosis. In plain terms, scar tissue forms around and on top of the follicle. Biopsies of balding scalp tissue have found collagen accumulation in the perifollicular dermis, the tissue that wraps around the lower portion of the follicle. In some studies, up to 70% of patients with pattern hair loss showed moderate to severe fibrosis in this region. What does fibrosis do? It compresses the tiny blood vessels that supply oxygen and nutrients to the follicle. It obstructs the diffusion of growth signals. It essentially walls off the follicle from the communication network it needs to function. In addition to fibrosis, another under-discussed phenomenon is scalp calcification. Calcium deposits form in the galea aponeurotica, a flat fibrous sheet that sits just above the skull and beneath the scalp. Research published in the International Journal of Trichology has documented this calcification in biopsy samples from balding regions, and it has been linked to restricted blood perfusion in those areas. This is a crucial piece of the puzzle, because it explains why so many topical treatments, even ones with genuinely good evidence behind them, produce disappointing results for a subset of people. The active compounds simply cannot penetrate a tissue that has been physically hardened and compressed. The remedy is not the problem. The barrier is the problem. DHT, the hormone that is blamed for everything now. Most people who have done any research into hair loss will have heard about DHT, dihydrotestosterone. It is a potent androgen derived from testosterone through the action of an enzyme called 5-alpha reductase. DHT is well established in the literature as a key driver of follicle miniaturization in genetically susceptible individuals. Here is how it works. DHT binds to androgen receptors in the dermal papilla cells, the cells at the base of the follicle that control its growth cycle. In individuals with a genetic sensitivity to DHT, this binding triggers a cascade that shortens the anagen phase, the active growth phase, and prolongs the telogen phase, the resting phase. Over time, each successive hair becomes thinner and shorter, until eventually the follicle stops producing visible hair at all. However, and this is important, DHT is not inherently a villain. In other tissues, DHT plays critical roles. It is essential for puberty in males, for the development of secondary sexual characteristics, for libido, for muscle regulation, and for mood stability. Research has shown that DHT has significant anti-anxiety effects in the brain, likely through its interaction with GABA receptors. This is why synthetic DHT-blocking medications, such as finasteride, carry documented risks of mood disturbances, depression, and sexual dysfunction in a meaningful subset of users. The goal should never be to eliminate DHT. The goal should be to address the upstream conditions that are causing DHT to have an outsized, destructive effect on the follicle, and that brings us to what I consider the true root cause of pattern hair loss. Insulin resistance. The upstream driver. Nobody tells you about insulin resistance is a condition in which the cells of the body become less sensitive to the hormone insulin. The pancreas compensates by producing more and more insulin. But this chronic hyperinsulinemia, high circulating insulin, has widespread metabolic effects that extend far beyond blood sugar regulation. What does this have to do with hair? A great deal. First, let us establish something fascinating about hair follicle biology. Unlike most cells in the body, hair follicle keratinocytes are obligate glucose consumers. They rely on glucose, not fatty acids, not ketones, as their primary energy substrate for rapid proliferation during the anagen phase. This was confirmed in a metabolic study published in the Journal of Investigative Dermatology, which showed that follicular keratinocytes maintain high rates of aerobic glycolysis, what is known in oncology as the Warburg effect. Now, here is the paradox. In a state of insulin resistance, despite elevated insulin levels, glucose uptake is impaired in insulin-sensitive tissues. If the follicle is not efficiently absorbing glucose, its capacity to sustain rapid cell division is compromised. But the impact of insulin resistance on hair loss goes even deeper. Chronically elevated insulin has 3 additional effects that are directly harmful to the follicle. The first is vascular. Insulin resistance is associated with endothelial dysfunction, impairment of the cells lining the blood vessels. This reduces nitric oxide production, which is the main mediator of vasodilation. Reduced blood flow to the scalp means less oxygen, less nutrient delivery, and less clearance of inflammatory metabolites around the follicle. The second is inflammatory. Insulin resistance is a pro-inflammatory state. It drives the production of inflammatory cytokines, including interleukin-1 beta, TNF-alpha, and prostaglandin D2. A landmark 2012 paper in the Journal of Investigative Dermatology showed that prostaglandin D2, PGD2, is significantly elevated in balding scalp tissue, and that it inhibits hair growth by binding to the GPR44 receptor on dermal papilla cells. This inflammatory environment also directly accelerates the fibrosis process I described earlier. The third is hormonal. Insulin resistance elevates androgen production. Specifically, it stimulates the ovaries and adrenal glands to produce more testosterone, and it upregulates 5-alpha reductase activity, meaning more of that testosterone is converted to DHT. So insulin resistance does not just impair the follicle's energy supply, it also amplifies the very hormonal signal that is driving follicle miniaturization. A remarkable 2023 case report published in the JAAD Case Reports, Journal of the American Academy of Dermatology, documented a man with classic androgenetic alopecia. His fasting blood glucose was within normal range, so standard screening would have given him a clean bill of health. But his fasting insulin was dramatically elevated. He also presented with acanthosis nigricans, a dark, velvety discoloration of the skin around the neck, which is a classic dermatological marker of insulin resistance. He was given a single pharmacological intervention targeting insulin resistance. No topicals, no finasteride, no hair-specific treatments. Within 6 months, substantial hair regrowth was documented across the previously balding areas. The regrowth was attributed entirely to the correction of the underlying metabolic dysfunction. This is an extraordinary data point. It tells us that for at least some individuals, the hair loss is a symptom of a systemic metabolic condition, and treating the root cause can restore hair growth without any hair-specific intervention at all. Correcting insulin resistance. The dietary approach. So, how do we address insulin resistance without medication? The most well-evidenced dietary strategy is carbohydrate restriction. A ketogenic or low-carbohydrate diet reduces circulating insulin by limiting the substrate that triggers insulin secretion. Meta-analyses and randomized controlled trials have consistently shown that carbohydrate-restricted diets produce significant reductions in fasting insulin, improvements in insulin sensitivity, and reductions in inflammatory markers. But diet alone is not sufficient for maximum benefit. Combining carbohydrate restriction with intermittent fasting is a powerful amplifier. Fasting triggers a process called autophagy, the cellular self-cleaning mechanism by which damaged proteins and organelles are recycled. Research from the Nobel Prize-winning work of Yoshinori Osumi has shown that autophagy plays a critical role in stem cell activation, and more recent work has suggested that it can reawaken quiescent tissue stem cells, including, potentially, hair follicle stem cells. Exercise is another essential component. A 2021 meta-analysis in the British Journal of Sports Medicine confirmed that resistance training and aerobic exercise both significantly improve insulin sensitivity, with combined training protocols producing the greatest effect. Exercise also improves scalp blood flow directly through enhanced cardiovascular function and nitric oxide production. Beyond diet and exercise, specific micronutrients are well documented in the hair loss literature. Zinc is a cofactor for 5-alpha reductase inhibition. A study published in Annals of Dermatology found that serum zinc levels were significantly lower in patients with androgenetic alopecia compared to controls, and that zinc supplementation produced improvements in hair density scores. Vitamin D has a well-established role in hair follicle cycling. Vitamin D receptors are expressed in the hair follicle, and vitamin D signaling is required for the transition from telogen back to anagen. A systematic review in Dermatology and Therapy confirmed an association between vitamin D deficiency and hair loss conditions. Iron, particularly ferritin, is another critical variable, especially in women. A 2013 review in the Journal of the American Academy of Dermatology recommended maintaining ferritin above 70 nanograms per milliliter for optimal hair cycling. Suboptimal ferritin is extremely common and consistently overlooked in standard hair loss workups. Omega-3 fatty acids reduce the prostaglandin D2 pathway that promotes hair loss. A 6-month randomized controlled trial published in the Journal of Cosmetic Dermatology found that omega-3 and omega-6 supplementation reduced hair loss and improved hair density in women with thinning hair. Breaking down the physical barrier. Microneedling. We now need to address the fibrosis barrier directly, because even if you have fully optimized your metabolic health, the scar tissue that is already formed around the follicles needs to be mechanically disrupted before topical treatments can reach their target. The most evidence-supported method for doing this is microneedling, also called percutaneous collagen induction therapy. Here is the mechanism. A dermaroller or microneedling device creates controlled micro-injuries in the scalp. This triggers the wound healing cascade. Platelets aggregate, growth factors are released, particularly platelet-derived growth factor, PDFG, and vascular endothelial growth factor, VEGF, and the old, disorganized collagen in the fibrotic tissue is broken down and replaced with new, healthier collagen architecture. But the benefits go beyond just disrupting fibrosis. A key 2013 study published in the International Journal of Trichology compared minoxidil alone versus minoxidil plus microneedling in men with androgenetic alopecia. After 12 weeks, the microneedling group showed a 40-fold greater mean hair count increase than the minoxidil-only group. The researchers proposed that microneedling activates hair follicle stem cells directly through mechanical stimulation of the WNT/beta-catenin signaling pathway, which is one of the master regulators of follicle cycling. For home use, the optimal needle depth for the scalp is 1.0 to 1.5 millimeters. Treatment frequency should be once every 2 to 4 weeks, no more, as you need time for the healing and remodeling cycle to complete. There is a 24 to 48-hour window after microneedling during which the skin's permeability is dramatically increased. This is the ideal time to apply topical actives because the microchannels allow them to penetrate far deeper than they would on intact skin. The topical stack. What the research actually supports. Let us go through the topicals with the strongest evidence base. Topical melatonin. This is, in my view, the most underrated hair loss topical on the market. The research on melatonin as a hair growth stimulant began with dermatological observations in mammals, where melatonin was found to regulate seasonal coat cycling. Human studies followed. A double-blind, placebo-controlled trial published in the British Journal of Dermatology in 2004 found that topical melatonin significantly reduced telogen hair rate compared to placebo. A larger study in 2012, involving over 1,800 patients using a 0.1% melatonin solution, found statistically significant improvements in hair density after 90 and 180 days. Melatonin has both antioxidant and anti-apoptotic properties in the follicle. It protects follicular cells from oxidative stress, and it may extend the anagen phase. Apply it at night, as it can cause drowsiness if absorbed systemically. Rosemary oil. The most cited comparison is a 2015 randomized controlled trial in SkinMed Journal that directly compared rosemary oil to 2% minoxidil over 6 months in 100 patients. Both groups showed equivalent hair count increases at the 6-month mark. The active mechanism is the compound carnosic acid, which activates the same WNT/beta-catenin pathway as microneedling, and also inhibits 5-alpha reductase. Critically, the rosemary oil group had a significantly lower rate of scalp itching and irritation compared to the minoxidil group. Saw palmetto, a lipid extract of Serenoa repens. Saw palmetto inhibits 5-alpha reductase activity and reduces DHT binding to androgen receptors. A 2020 review in Skin Appendage Disorders identified 5 clinical trials showing positive outcomes on hair density and hair count in androgenetic alopecia with saw palmetto, with a favorable safety profile compared to finasteride. Pumpkin seed oil. A 2014 randomized, double-blind, placebo-controlled trial published in Evidence-Based Complementary and Alternative Medicine found that men taking 400 milligrams of pumpkin seed oil per day experienced a 40% increase in hair count after 24 weeks, compared to 10% in the placebo group. The proposed mechanism involves 5-alpha reductase inhibition through the action of delta-7 sterols present in the oil. The cortisol connection. One final variable that is frequently dismissed in hair loss discussions is chronic stress. The relationship between cortisol, the primary stress hormone, and hair loss is both direct and indirect. Directly, a landmark 2021 study published in Nature identified corticosterone, the rodent equivalent of cortisol, as a suppressor of hair follicle stem cell activity. Elevated corticosterone was shown to reduce the production of Gas6, a growth factor that normally activates HFSCs. Remove the chronic stress signal, and the stem cells resume normal cycling. Indirectly, chronic cortisol elevation worsens insulin resistance by increasing hepatic glucose production, and promoting adipose tissue accumulation around the viscera, which further amplifies the inflammatory and hormonal cascade I described earlier. Stress reduction strategies with the strongest physiological evidence include long-form daily walking, which reduces cortisol through parasympathetic activation and reduces cortisol awakening response. Sleep optimization. Deep sleep is the primary window for cortisol clearance and growth hormone pulsatility, both essential for follicle regeneration, and supplementation with thiamine, vitamin B1, which supports mitochondrial function in the nervous system and blunts the cortisol response to metabolic stressors. Putting it all together. Your protocol. Let me summarize what the evidence points to as a comprehensive strategy. Step 1. Address insulin resistance. Move to a low-carbohydrate dietary pattern. Incorporate intermittent fasting. Add resistance training and daily walking. Have your fasting insulin tested, not just fasting glucose. If your fasting insulin is above 10 U/IU per milliliter, metabolic optimization should be your primary focus. Step 2. Correct micronutrient deficiencies. Test and optimize vitamin D, ferritin, and zinc. Supplement omega-3 fatty acids. These are not optional extras. They are foundational. Step 3. Break down the fibrotic barrier. Microneedle the scalp at 1.0 to 1.5 millimeters depth once every 2 to 4 weeks. Step 4. Optimize the topical window. Within 24 to 48 hours after microneedling, apply a topical stack, melatonin solution, 0.1%, as the primary active, with rosemary oil and saw palmetto as adjuncts. Step 5. Manage cortisol. Prioritize sleep. Walk daily. Consider vitamin B1 supplementation. Step 6. Be patient. Hair cycling operates on a timeline of months, not weeks. The anagen phase lasts 2 to 6 years. The results of these interventions will emerge gradually, but the evidence strongly supports that they will emerge. Hair loss is not a cosmetic inconvenience. It is a biological signal, and, like all signals, it is pointing you toward something deeper that needs to be addressed. Address the root, and the branch takes care of itself. I am Dr. Daniel, and I will see you in the next video.